Thank you, Ashley. I'm sorry you drew the short straw today when Skip bailed out on us, but first of all, I see one or two familiar faces in the room, which makes me worry if you didn't have something better to do for lunch today. But thank you for being here. Excuse me, the first thing I want to tell you is that in spite of the title slide, I'm not a technology expert, and for those of you who in the room who know me, you're wondering, what in the world is Ray Scott doing in a job like that, right? So the takeaway from that is, while we talk a lot about technology and while it is a focus of what we're working on, the end product that we're after is really not the technology, right? It's a means to an end. It's a tool that we want to use. And I would be remiss if I didn't echo the kind of special mention about Lindsay Clark, who is a Clinton School graduate that we were privileged to have as a part of our team until she kind of landed her eyes on a bigger prize called med school. And she's now gone back to Ohio to pursue a dream, and we're going to miss her dearly. But she came to me and she said, I really think you should do a presentation at the Clinton School. I've talked to him, and I said, why don't you do the presentation at the Clinton School? I lost that argument. So I wish I had a 3-minute elevator speech I could take you through today, but unfortunately it's more complicated than that. So what I am going to try to do is take you quickly through, I guess, about a 30,000-foot level of what it is we're trying to do, why we're trying to do it, and why we think you as a healthcare consumer should not only care, but also be actively engaged in helping us get this done, okay? Now, what we have to hope is the technology works, right? If we could start by, for some of you in the room, I won't call any names. You don't have to imagine, all you have to do is remember, okay? For others, Ashley, you have to imagine, but I actually remember a time when this is how things worked, or didn't work, should we suggest, okay? But think about the progress that's been made in all of these areas around how we bank, how we communicate, how we make financial transactions and decisions, okay? So, unfortunately, in the healthcare world, things are not quite that current, nor that fluid, nor that easy, right? Now, I'm sure none of you in the room have ever had any of these experiences in your entire life of pursuit of healthcare, right? Well, the obvious is let me make clear, we're not talking about health technology. We're not talking about gamma knives and CT scans, and it's clear we've made huge strides in how we're using technology to provide and drive the healthcare process. Where we haven't made those same kind of strides in how we're using health information, like we're using information, the ones and zeros in all of those other areas that we just looked at. Part of the reason for that is what I like to call the silos of uncoordinated care. Or another way to talk about it is discontinuity in our healthcare delivery system. Let me ask for a little audience participation here. Is there anybody in this room, and there may be, who actually only sees one physician and that person takes care of all of your healthcare needs? I didn't see a single hand go up. Okay, I'm done. I just made my point. The thing I find interesting is I do presentations to groups like this, and we have a Q&A process, is the number of people who kind of automatically assume because information is where they want it, when they want it, for the purposes they want it, in their cell phones, in their ATM cards, and those kinds of things. There's this assumption that in the healthcare world, all of our information kind of magically moves with us, right? Well, it doesn't. And part of the reason it doesn't is because of these silos of care where we see a family practitioner for one thing, we go to a clinic for another thing, we go to the hospital, unfortunately, sometimes for other things. And the problem is those folks don't talk together. They don't talk with each other. More importantly, they don't actually exchange meaningful information that actually can be critical in terms of informing the care process. Last week, President Obama declared National Health Information Technology Week. And in a webinar that we participated in, HHS Secretary Sebelius said that this is particularly an acute problem for folks who are managing chronic conditions, right? In the United States of America, on average, senior citizens who are managing only a handful of chronic conditions see, guess how many docs in a year? 14, okay? Now, for those of us that have actually tried to help elderly relatives or family members navigate the healthcare system, we get it. We've kind of been through that, and it was not a pleasant experience, not only for us, but more importantly for the patient. So the question is, how do we begin to connect all of these silos of care? What we in the state of Arkansas are trying to do is build what I describe as a pathway, a utility that actually can move health information over a private and secure network, that it moves with us as we navigate the healthcare system, and it's where it needs to be, when it needs to be, to the person authorized to access it to help inform the care that we also need. And that's what a health information exchange is. At the end of the day, it's how do we make health information more liquid, more valuable, and more readily accessible, again, in a private and secure way that respects and honors your privacy. So when we talk about, you can't talk about healthcare, much less much in government, without the alphabet soup, right? So HIE, Health Information Exchange, is a part of our alphabet soup, but I think it's important to just lay 4 basic building blocks, if you will, of what Health Information Exchange requires in order for it to be done successfully. So number one, some of you technology people in the room probably understand this more than others, but part of the problem we've had in the healthcare arena is we have standards that are not standard. Okay? I see people scratching their heads. We have standards that are not standard. And that's, in some respects, kind of an inside joke in the healthcare arena. But we have multiple ways in which communication gets moved from point to point. There are various formats. Not every electronic health record product is built on the same platform, uses the same format. Fortunately, what is actually happening, and we're now making progress, we're actually beginning to build standards that really mean something, okay? So they're evolving nationally. That's one major building block, and we're making progress. Secondly, I can't think of any major innovation that's occurred in our society in which consumers haven't played a huge role in driving it, okay? Consumer demand. I don't think it's going to be any different in this arena as we as patients and or the folks who pay for the care that we're getting, meaning the insurance companies and our employers in most cases, as we begin to make more demands for better information, to better inform care, to help us manage our own care, the more valuable this is going to become and the more responsive I think the industry is going to be. So consumer demand is a second critical block. The ultimate objective, not the ultimate, but one of the critical objectives is the adoption by the provider, healthcare provider community. And this is in fact becoming, and I think this is going to happen sooner rather than later, a standard of care. So what does that mean? It means that there's going to come a day when we're going to start seeing healthcare reimbursed not simply on procedure codes, but also on outcomes, on results, okay? And the only way that's going to work is if we have these critical pieces of health information to actually inform, monitor, track, and evaluate what happened. Not just the encounter, not just the procedure code, but, over time, are we making progress? Is health status changing and improving? So it does start, though, with convincing the provider community, and we mean physicians, hospitals, labs, pharmacies, that doing business with fax machines and 6-inch thick paper files ain't going to get it. And what's going to happen, what's already happening, is that the payers, both public payers, which means Medicaid and Medicare, and private payers are already beginning to insist, in fact, if not demand, that providers move to adopt and use electronic health record technology in a meaningful way. And I'll talk a little bit more about that. There's a series of steps, literally, building blocks beyond these four that have to be addressed. I think it's important for me to say quickly, too, that what I'm here talking about today is not what I am doing in the Office of Health Information Technology. What we are trying to do through our office is connect the dots, but there is a large cast of characters and players that are all carrying an extremely critical part of the load of us trying to advance this initiative down the road. So let me walk you through quickly the various players that are graphically presented here on the steps. First and foremost, we do have the provider community, particularly physicians and hospitals. The HITECH Act actually delineates and defines a group of providers that are actually eligible for some incentive payments, and I'll talk a little bit more about that in a later step. But it's really important to understand that the ultimate objective at the top of that staircase, you can barely read it up there, it says meaningful use. Meaningful use is a new term of art, but basically what it means is not only must you adopt and use the technology within the confines of your practice, meaning change the way work flows, change the way information flows. More importantly, the information needs to be used in a meaningful way, a way that it actually informs care decisions. You know, a recent medication history could make a huge difference in terms of whether or not certain procedures need to be done or whether additional changes in meds are indicated. If you go back to one of those very first slides, if you go to the doc and the doctor you're seeing today doesn't know that the doctor you saw 2 weeks ago or 2 months ago changed a prescription and you forgot about it, or you get old like me and can't remember what you used to be able to remember, you don't remember to tell the doctor. Those are pretty critical pieces of information. So using information in a meaningful way. So my point earlier about it's not about the technology, yes, adopting it and using it is critical, but let's use it in a meaningful way, not just to make your bills get filed, your claims filed quicker, or your payment processed faster, but let's use it in a way that it actually informs patient care. A critical piece of this puzzle in terms of the steps is the Regional Extension Center, which is another recipient of federal grant funds in our state, headed up and run and managed by the Arkansas Foundation for Medical Care, which some of you are familiar with. The critical job these folks have is they are what we generally lovingly refer to as the boots on the ground. They literally have staff out knocking on physicians and hospitals' doors saying, let us talk to you about all the reasons why you need to agree to adopt and use electronic health record technology. Yes, it's a challenge. Yes, it's going to cost you money, but we have answers. We can help. They do consulting work. They provide technical assistance. They've already developed kind of a list of preferred products based on their evaluation. They're suggesting to physicians and the hospital community that these are record systems that we think we can provide ongoing support beyond what your vendor is going to provide when you buy that product. So they are a very critical piece of this process and puzzle. I mentioned the incentive payments. The federal government actually is making your tax dollars and mine available to the physician and hospital community to incentivize them to adopt this technology. They're not suggesting that this money is going to be a full compensation or reimbursement for what you do, but they are thinking it can make a difference. And again, I'm not going to go into the details and weeds, but physicians can qualify either for Medicaid or Medicare incentive payments. And importantly, it's not a clinic qualifying, it's the individual provider. If you've got a clinic with 4 docs and all 4 docs meet the eligibility criteria, then in Medicaid it's about $64,000, then it's each doc who meets the qualifications gets that. So pretty soon you're talking real money, okay? So again, this incentive payment it's a tool. Dr. Phil Mizell, who is kind of a chief medical information officer for my office, suggests to the physician community, you shouldn't do it just because there's an incentive payment. You should do it because it's the right thing to do and because it actually can help you provide a higher quality of patient care. I like Dr. Mizell. So let's say we're successful, that the physicians have agreed to adopt the technology. The Regional Extension Center has been incredibly successful of getting the docs to agree to sign up and get the help they need. The docs have the electronic health record systems, and they're now ready to actually use them. They want to use them in a meaningful way. They want to move information from point A to point B. In Chico County, Arkansas, it's a dial-up. You can't do what you want to do with that technology, okay? So another critical piece of this is how do we make sure the connectivity is out there where it needs to be, so every physician in this state who wants to take advantage of this technology can get online, move the information in a way that needs to be moved, and broadband is a key part of that. So we have broadband partners. UAMS is doing an enormous amount of work trying to extend broadband access throughout the state. Connect Arkansas, which is another private nonprofit entity, are doing a huge amount of work around trying to educate the consumers in our state about the value and use of broadband, and also trying to improve access to it. So that's another critical piece. I tell folks all the time, while I spend a lot of time talking to the healthcare community, I also spend a lot of time talking to the telecommunication industry and other folks who are all critical players in this process. So if we're successful up to this point, they bought it, they're using it, and we got them connected. Anybody in this room ever bought a piece of hardware or software and never had to touch it or do anything with it from that point on? Let me see your hands quick, because I want to buy what you bought. So here we are pushing this technology, telling folks, you know, this is the way to go. They agree and they do it. We got to have some way to make sure they get the support they need to keep it operating, to keep it updated, et cetera, et cetera. So we have another partner, the National Park Community College in Hot Springs, was the recipient, again, of a federal grant, your dollars and mine, to actually develop an online course to train, educate and train an IT workforce. So anybody anywhere in this state who can meet the qualifications, if you will, can enroll in this course and actually go online and get training as an IT support specialist. They have multiple roles that these folks can play. And importantly, it's all online, right? Now, I have to tell you one quick story. You would think that given the unemployment situation that we're dealing with, not only in Arkansas but around the country, this would be a great opportunity, but I must tell you the uptake, the take-up rate on this opportunity has not been what we had hoped for. So one of my colleagues, and I believe it was the state of North Carolina, they came up with what they call the high-tech redneck strategy. And I laughed when I heard that, but the wisdom of it is these are not the kind of jobs you're going to have folks moving from, you know, California to come to Arkansas to be an IT support person, but we can darn sure grow our own. So I'm all for a high-tech redneck strategy for the state of Arkansas, because we've got to have this IT support out there, and we know, particularly again in small rural communities, job opportunities are not particularly plentiful. So we're hoping that over time this will actually begin to become another career path opportunity. The other critical step in this process is, again, this health information exchange entity in our state we call SHARE, State Health Alliance for Records Exchange. Think of it as a public utility, think of it as a healthcare utility, think of it as a pipeline into which this information can go, can be moved in a highly private and secure way so that your personal health information is in fact protected. Okay? So here's how we think health information technology can actually make a positive difference. The RAND Corporation several years ago did a national analysis and predicted at that point we actually could save about $80 billion a year out of our healthcare expenditure if we could do a more effective way of using, find a more effective way of using health information technology. Secondly, you know, they didn't use the term stimulus for no reason. If we take advantage of all the federal funding opportunities that came our way through the HITECH Act, over 5 years it actually could mean $500 million of economic stimulus to the state of Arkansas. Importantly, though, what we don't want to happen is we don't want those funds to just be used in, again, siloed ways where we're creating a lot of standalone initiatives that aren't somehow connected themselves. So this whole idea of how we leverage these opportunities and make sure that what the Regional Extension Center is doing, what the National Park Community College is doing, what I'm doing, what the Medicaid program is doing, that we're all communicating and working in a highly collaborative way. And trust me, we are. We spend a lot of time on the phone. We spend a lot of time in meetings trying to figure out how we're all going to connect to make this work. The other thing I want to point out is that health information has always had value, but I think one of the byproducts of all of these various initiatives that are going on is that it's now become what I describe as the new currency of the healthcare marketplace. That information is going to have value unlike it's ever had, especially if we use it the way it needs to be used. Use it to inform care, use it to monitor quality, use it to do public health surveillance. You know, think about for a moment around public disease outbreaks, you know, H1N1 and things like that, where we're relying upon physicians' offices and hospitals reporting to us in ways that take weeks. What if the Department of Health could have that information in hours by being able to do surveillance through the electronic health records and the private data vaults that we're going to build to store this information only for those that are authorized and authenticated to get to it. So at the bottom of the slide here, I just highlighted a few of the many things that are going on in this state right now. As we describe in our world, there's lots of balls in the air and lots of plates spinning right now. And trying to keep all of those things connected is a full-time job. But the common denominator and the key ingredient in making all of these things work is, guess what? Health information. More effective use of health information. So, if we can do it and do it right, how can it make a difference? Well, these are the things that we think, not just because we believe it, but because organizations who've already been down this road, Kaiser Permanente, the Cleveland Clinic, Johns Hopkins, Harvard, a lot of prestigious healthcare delivery systems around this country. The state of Indiana, particularly in the Indianapolis area, they've been doing this for 25 years. They have not only demonstrated, but actually proven what a difference more effective use of health information can make in the whole healthcare delivery process. And so that research is out there. It's not the technology, folks, that's preventing us from making the leaps that we need to make in how we are delivering healthcare in this country. It's resistance to change, it's cost, it's, I guess, a healthy reservation about, you know, am I going to be able to still practice medicine the way I practiced it for the last 20 years by going this route? So a part of our job is to make sure that we have good answers to all of those questions and those challenges. Another reason we need to do this is because there's a lot of waste, not intentional, but there's a huge amount of opportunity to improve the way we're spending the healthcare dollars we are spending. It's not that we need to spend less, we need to spend wiser. We need to spend it in a more effective way. So this is just one study that was done that showed this kind of opportunity back in 2008. The point is that these are at least what these folks described as avoidable medical errors. So there's huge opportunity here. A second opportunity we have is the readmission rate that hospitals in this nation are experiencing. And this data only speaks to Medicare. Doesn't include Medicaid, doesn't include private insurers. But if you can't read those slides, I just want you to look at this. Now think about this for a moment. This is of all Medicare patients admitted to hospitals, 1 in 5 were readmitted within 30 days. 1 in 3 were readmitted in 90 days, and the most alarming statistic of all is 50% of the people who were readmitted saw no physician between discharge and readmission, which in and of itself is probably part of the reason they got readmitted, right? So again, there are huge opportunities here. Not only are there opportunities, but I regret to inform you that starting next year, there are actually going to be standards established for hospitals to meet. There are going to be tolerance levels, if you will, around what a reasonable readmission rate should be and could be. If they don't meet that, then there's the opportunity for the federal government to withhold payment from their Medicare reimbursement, which is not where we want to be. So again, opportunities to do what we're doing better. Quickly, by the end of this year, our requirement and our expectation is that we will have a health information exchange capacity in the state to do 3 fundamental things. And let me point out to you too that we're not the sole purveyor of this technology. There are a number of large clinic systems and hospital systems in this state that long before there were stimulus dollars available, they made wise clinical and business decisions to do this on their own. Baptist Health, Jefferson Regional Medical, the federally qualified health centers, the community health centers all over the state have 100% adoption in electronic health record technology. So don't misunderstand me that, we've somehow all of a sudden discovered that we've got the answer. So there's a lot of opportunity already out there. So for a lot of those folks, this seems like a very small step. But think about trying to do this statewide, regardless of what record system you're using, regardless of what operating system your computers are working on, and regardless of what kind of capacity infrastructure-wise you have in your town. The 3 things we are hoping to be able to do by the end of this year is to help to facilitate and enable providers, physicians, and pharmacies to do e-prescribing. Secondly, to allow the exchange of what's generally referred to as structured lab results. And I might point out that one of the objectives there is actually to have the lab results readable and understandable. Okay? Wouldn't that be a novel idea? Last but not least, the ability to exchange clinical care summaries between Dr. Scott and Dr. Hardage to inform my care. Okay? And then last but not least, we need to be able to do this through what's generally referred to as a secure message environment, which means that what you don't want is a doctor putting your recent test results or clinical summary on email and sending it across Google or Yahoo or Comcast, or it needs to be sent in a private and secure way that honors and respects the HIPAA requirements. That's phase 1. Phase 2, we want this exchange to be able to do more, to make more happen, to make more information available. The ability to do what I talked about earlier, what's generally referred to as syndromic surveillance, where the public health department can actually do queries. Tell me how many prescriptions were written in the last 90 days for this antibiotic, which is a pretty darn good indicator of what's happening around various kinds of infections, or do a query around diagnostic categories and things like that. But all of that's coming down the line, Importantly, we also want to have a patient portal where consumers can access some form of a a personal health record. We think it's really important that the more informed a consumer is, the better partner they can be in delivering. Now, I'm always asked, how can I be assured that you're going to do this in a way that you respect my privacy and the privacy of my information? Well, all I can tell you is my best example is I like to describe the health information exchange as being HIPAA on steroids. If the doctor's office is going to maintain the sanctity and privacy of your information in their office, we can have no less standard when that information leaves that office and goes down this pipe. So it's HIPAA. On top of HIPAA, we have privacy policies that have now been developed around how we are going to enforce and require the same kind of protections, the same kind of privacy requirements that are required under HIPAA and more. So a colleague of mine in another state said his governor asked him, well, are we making the kind of progress we need to make, and are we moving as fast as we should move? His answer was, Governor, we're moving at the speed of trust. The point being is if we can't gain the confidence and build the trust, then we're not going to make much progress, right? So this is, you talk about a critical building block, I call this the lifeblood of whether health information exchange can in fact work and do what it needs to do. Real quickly, it's really not about technology. I've made that point. Secondly, don't forget the consumer. They are a major part. Thirdly, it's not a matter of if we're going to do this, the question is when, and the quicker we embrace it and get on with it, I think the better off our healthcare system in this country will be. Another point is we don't want to reinvent the wheel. We want to build on what's out there and what's working. All of this investment I talked about that these different healthcare organizations have made, we're not going to go to them, trust me, we're not going to go to them and say, you know, you did a great job, but that's not enough, or it's not good enough, or it's too old, you got to do it again. That's not going to work. So part of our challenge is how do we link these pieces together to create kind of a network of networks. Right now, all of this is being driven primarily by your government. I'm a representative of your and my government. I think for the long term, this is probably not something state government is going to do forever and do well. I think a public-private partnership is actually where this probably needs to wind up. But Governor Beebe's point, and I agree with him completely, is that right now his name's on the mortgage. The Fed's made the down payment with all these grant dollars, but ultimately it's the state that's at risk and responsible. And until he is convinced that we have reached a level of maturity and progress, he's not ready to loose the reins on how this money's being spent. But I think long term it does need to be something more than just a government project. Importantly, we have a problem in this state called health disparities. I think most of you know what I mean. There have been many people to stand at this podium making that point before. We've got folks that are not getting equal access to quality health care in this state. The most damning statistic I know of, there's a 10-year difference in life expectancy for folks who live on the eastern side of the state and folks who live on the western side of the state. Now, there are a lot of reasons for that, but health care and health disparities is a major cause of that. So technology, we believe, can actually help close that threshold, help close that Grand Canyon, and we darn sure don't want it to create a digital divide. Foster innovation. You cannot talk about technology without talking about innovation. Anybody who bought an iPad 1, right? 3 weeks later, gosh, iPad 2, well, you know, now iPad 3's probably. The point is, once you buy it, the day you plug it in, you need to start thinking about how you're going to replace it, update it. So we got to think about that. Last but not least, we have great collaboration. All those partners that I talked to you about, it's a coordinator's dream and a coordinator's nightmare because I'm surrounded by a whole lot of folks a lot smarter than me. That's the good news. But it's also my job to try to keep all the parts connected. But we've got great partnerships in this state working every day trying to make sure we do it right, okay? There's how you find me. I'm actually pretty good about responding to email, usually between 1 and 6 a.m., but that's my problem. And then just to show you we haven't totally lost our sense of humor. Thank you very much.
We do have time for some questions. If you raise a hand, we'll get a microphone to you. Any questions? Behind you? Oh, that side. Right there. Hold on.
I have old rock and roll ears. I need that mic on. No, sir.
Can you hear me now?
Yes, sir.
In a highly mobile society, how can this program benefit those patients who move across state lines and also physicians and other healthcare practitioners who also move across state lines? How do you keep uniformity and keep the purpose of this program intact?
Very good question. How can we make this information available across state lines? Several answers to that. Number one, we're only one of probably 40-something states that are now doing this. There are 10 or 12 that are already down this road. They started 5 or 6 years ago. But the ultimate objective is to have every health information exchange in the country, every state's HIE, actually be able to communicate with each other. Number two, think about the number of people who live in border cities in our state who don't just, you know, I don't know about you, but I don't get all of my health care in the city of Little Rock. You know, I had an eye surgery done up in northwest Arkansas. We have people who live in West Memphis who get the bulk of their health care in Memphis, Tennessee. So there's, I hate to tell you, there's a Ray Scott in every state who's got this same job. And so a part of what we actually have to be able to demonstrate to the feds is that we are developing ways in which we can communicate across state lines.
Right here.
Don't give him the mic, please.
Ray, you've talked primarily about hospitals and physicians and the acute care side. Certainly one of the challenges is how do we integrate the information from mental health delivery and mental health providers?
Right.
Has your team looked at any special concerns or issues or systems that might really help facilitate that?
Good question. Part of the challenge, John, was that when the Congress decided this was the way they wanted to move, and the current administration did, clearly there's as much stimulus money as was made available. There was not an opportunity, quite frankly, to include every medical specialty and every healthcare setting. And so, quite frankly, the priority and the primary target was to start with the primary care sector, if you will. Having said that, though, you know, we're in conversations right now with the dental community, with the long-term care community, with the behavioral health community, that even though there may not be incentive payment dollars specifically earmarked for you, that doesn't mean that there are not other ways you might consider adopting and using electronic health record technology. And trust me, I think the HIE, the Health Information Exchange share, we're going to take all willing comers. You know, you don't have to have an MD after your name to connect to the Health Information Exchange, again, assuming we can manage all the authentication, authorization, credentialing. I don't mean credentialing professional, I mean security credentialing. So, John, unfortunately, we don't have earmarked money to be able to say to these folks, here are incentives for you to come. But I will tell you this, I was actually at the rental center on Saturday doing a similar conversation around long-term care, and, you know, based upon particularly my personal experience in the field, there's no way to change and improve the way we deliver health care in Arkansas if you exclude long-term care, just given the demographics of our state, okay? So what I like to, I'm gonna try not to get on a soapbox, a target-rich environment, if you'll pardon that term, from my perspective is think about transitions of care. Every time an individual moves from home to a facility, from a nursing home to an inpatient hospital, from a hospital to rehab, a rehab to home health, every time one of those transitions occur, there's either an opportunity for us to do it really well or an opportunity for us to not do it well at all. And I'm telling you from my understanding, it's the latter that occurs most often. Patients get sent from nursing homes to acute care hospitals, and the medication record may or may not be accurate and up to date. The 6-inch thick file they sent from the nursing home may have made it into the ambulance and made it to the hospital with EMTs. It may not. So there are states that I've been in contact with that have actually decided that's a huge way they can demonstrate the value of this technology by just doing nothing else but developing a kind of a 12 critical data point document called a TOC-doc, a transition of care document. And basically, in that state, the requirement is the patient can't move from point to point unless that information either accompanies them or precedes them. They actually do it well from nursing homes to hospitals. They send it electronically to the hospital, and it's there before the patient ever arrives. They also give a paper copy to the EMTs. And so there are opportunities like that, John, that we need to identify that doesn't require an incentive payment, doesn't require federal authorization to do it, but then the onus is on us to figure out how to pay for that. Does that make sense to y'all as you move across the healthcare system and you go from threshold to threshold? I just hate to tell you this, but trust me, your information does not follow you. It doesn't. Yes, ma'am. Oh, I'm sorry. I'm not running.
We'll start here and then we'll get to you.
All right. I'm Chen Yihu from UCI Computer Science Department. And this department put a heavy interest, emphasize on health informatics, health information technology. We hope to know how can we be involved, can contribute to the project. The connection is between academics and the government
Absolutely.
office.
Very good point. Health informatics, which is really about how we use health information to drive critical healthcare decisions, critical resource deployment decisions. You know, for example, the state Medicaid program could use a healthy dose of better use of the information they're sitting with in their files to inform maybe we're paying for things that aren't achieving the results we want them to achieve, but if we don't use the health information to do the informatics and analytics, we're not going to know that. So thank you. I want to talk to you.
Yes, ma'am.
I'm coming from the consumer standpoint.
Yes, ma'am.
I'm one of those that reached 65, and my doctor said, "Bye, darling, I love you, but you know, you have Medicare." She would laugh at your $64,000 to help her put in a electronic file because she would say, you know, Medicare doesn't even pay enough for me to see my patient, much less Medicaid. Is anything in your system being addressed? I mean, there are a lot of people out there that are no longer getting appropriate care, that disparity of care, simply because we have no physicians anymore because we either have, in my case, Medicare, and certainly those that have Medicaid. Is anything being thought about within the system as to how we can reach more physicians to keep them involved in public health care?
Very good question and a very good point, and that is a concern. I mean, we have had, I hate to tell you this, we've actually had physicians say, well, before I go there, I'll just sell my practice and retire. Now, I will tell you anecdotally, I was in a meeting with a group of docs. There's a generation gap here. The younger docs think we're not moving near fast enough. The older docs wish we'd go away. When the older doctor made that comment, the younger doctor turned to him and he said, well, have you thought about what the value of your practice is going to be with a warehouse full of 40-year-old paper records? And the older doctor went, hadn't thought about that. What we don't want to do is create incentives for docs to quit practicing. Frankly, we know in this state we don't have near enough primary care practitioners as it is. All I can tell you is that we're sensitive to that. We're aware of that. The Regional Extension Center, the folks that are out there having these conversations with the docs are aware of that. I would just remind you that the incentive payment dollars are again available on an individual physician by physician basis. If you're in a clinic and there are 4 doctors and all 4 of you qualify, do the math. It's 4 times $64,000, okay? So again, they've got to be eligible and they've got to qualify. So again, the incentive payment program was never intended to fully compensate or fully reimburse you for what you bought. But I have to go back to Dr. Mizell. I'll also tell you my personal cardiologist and his clinic of 22 cardiologists made this decision 6 years ago. He said, Ray, here's what I can tell you. It cost us twice as much as we were told it would cost, and it took us twice as long to get it installed. But if you gave us all of that money back and then some, we would not go back to paper records under any condition. So, you know, it's both a clinical decision in terms of how you want to practice your care. It's also a business decision. And that's about the best I can do. We don't have a remedy for all of this, but again, a part of our challenge is to do it in a way that it puts as few obstacles and barriers and excuses for why I don't want to do it in their way. We're all about knocking those barriers down and coming up with the answers when and where we can, but there is a limit to how much money we have. And I will tell you this, I must tell you that Medicare is kind of the missing in action part of this. I'm not terribly encouraged about the extent to which Medicare, which as you know is run at the federal level, not state by state, to which they are reluctant to commit either finances or we're making some progress on the sharing of data. And in this state, sharing Medicare data is a big deal when you look at our demographics. So, you know, I don't in any way mean to suggest this is easy. I tell folks it's a marathon of mega proportions. You know, there's not a single healthcare entity in the country that we're aware of who's done this and done it successfully in anything less than 5 to 7 years. And I'm talking about starting from nothing to a fully functional, highly operational HIT environment. And we're in year 2. I'm talking about as a state. So I don't know if this will happen on my watch or not.
Any other questions? Oh, right here.
Thank you. I appreciate what you're doing. I think it's really important. I'd be interested in how consumers are engaged in designing the system that you're and implementing the system.
Thank you. Well, I should have started off with this. The number one job that Lindsay Clark, graduate of the Clinton School, had was identifying and seizing opportunities for consumer engagement. And one of the very first things we did, literally the first week or two that this office opened officially, was to create a consumer advisory council. The only criteria is you had to be a healthcare consumer, which means the universe, right? But we specifically did not want providers represented. We didn't want payers represented. So it's, you know, it's Arkansas Advocates, it's AARP, it's the Alzheimer's Association, it's the HIV/AIDS group, and what we have specifically tasked those folks with doing is keeping us honest, that as we're talking about all these great solutions and all this wonderful technology, don't forget the consumer, the bullet point on one of the next to last slides. So I'm not about to suggest to you we're done. We've only just begun, but we clearly have a very specific focus on consumers. I also have to tell you, I don't know, this was published about a year ago. I want to make sure I get the quote right. There's an annual survey about the availability of broadband access and utilization state by state. And the last report that came out last year showed that only about 51% of the population in Arkansas either has access to or is using broadband capability. So it's fine for us to think about how all of this can make a difference, but you know, we've still got a lot of folks who need to be able to pick up the phone and talk to somebody. They need to have somebody help them navigate. So I'm constantly reminded that while we think we can make a huge difference, this is not the silver bullet, right? This is not the only answer. So helplines, call centers, all of that are going to have to be a part of this equation. Thank you for that consumer question.
We have time for one more.
Ray, as a consumer, if I went to a physician, is there a question I ask to find out if they are participating in this?
There is. The very first question you should ask is, Doctor, are you currently using or planning to adopt electronic health records in your practice? And call me and tell me what the answer is, would you? I will tell you this. I have a family practice physician whom I love dearly. I've been seeing her for 20 plus years. On my last, I don't see her often because I have other conditions that require higher degrees of specialty, and I'll say no more. On my last visit to her a year ago, we had this conversation, and she looked me right in the eye and she said, Ray, I don't do computers. I'm not going to do an EHR system. I still handwrite my notes in your chart, and that's the way it's going to be. And I said to her, well, I really hate to hear that because your handwritten notes aren't worth a damn to my cardiologist. And she looked at me and she said, I get it, I just can't change. So I'm now faced with a decision about whether I want to keep using that same private family practice doc that I love dearly. But, you know, that's not adequate. And so when I talk about consumer driven and, you know, consumers being not in the driver's seat, but clearly having a voice, I know of private payers and I know of employers who are now actually saying, if you're not willing to agree to move in this direction, you don't have to have it done next week, but we frankly might take our business elsewhere. And that's actually happening as we speak. One of the largest payers in the state is working every day trying to figure out how to drive the adoption and use of this technology because they know they're paying for duplicate CT scans and lab results. And there's no need for that when we can do better. So ask the question.
Thank you, Ray, so much for
thank y'all
coming.
very much.
Thank all of y'all for
Appreciate
coming
it.
out today.